This is Evie.
This is Alyssa.
This is Chelsea.
And this is Caroline.
Welcome to Med Surg Moments, the AMSN podcast.
This podcast is an engaging look at the lives of and surrounding medical surgical nurses. Unfortunately, Chelsea can't join us today. She's at the call of duty at work tonight. We do, however, have our honorary co-host with us, Dr. Terri Hinkley. Thank you for joining us today, Terri.
Oh, my pleasure. And honestly, just Terri works great.
Excellent. Ladies, tell us what's new. What's been going on in the world around you?
I have not been out of my house on business purposes since March of 2020, obviously still working hard, but from my home office. And I got to put on like actual dress pants and go and do a Prism Award today. So congratulations, 7A,
Wow.
to Voorhees. Great job. It was a redesignation. I did their first Prism presentation 3 years ago, and it was fabulous to be back. The celebration was a little smaller, looked a little different, but we still celebrated them and all of their accomplishments. So that was a lot of fun.
Oh, that's way fun.
Fabulous. Down here in Florida, we have just come off a very successful Nurses Month and Hospital Week, and we were able to celebrate in a lot more meaningful manner this year than we were last. I think it's given us all a moment to reflect and see how far we've come and how the world is slowly but surely getting back to normal.
Wow, let's keep the celebrations going. Today, I was honored to be among 12 finalists for a Compassionate Caregiver Award. It was exciting. I didn't know what to expect. There were 106 nominees, I think, and then I was one of the 12 finalists. So that was quite an honor, and it was very nice. We got treated like royalty.
Oh, congratulations. That's a huge honor.
That is really cool. Let's see what's new. Nothing amazing to celebrate like you guys. I did have a great holiday weekend. I went camping, went and played with friends and family, but nothing as exciting as you guys. Just lame out in the desert, you know?
If it's exciting for you, then it's exciting. There you go.
There you go. Yes, I had a very great weekend. So there you go. All right, you guys, why don't we get started on our topic today? We're talking about the patient experience and patient scores. HCAHPS scores, I think, is probably the most known. So what is your experience with these surveys that are being sent out to your patients? Who wants to go first?
I have zero experience with HCAHPS. My professional experience, all my nursing experience was in Canada. And with the public system, we didn't collect that sort of data, or not in any way what's being collected down here with the HCAHPS score. So I'm actually really interested in hearing from all of you what your perspectives and insights are, because I do know what some of our members struggle with sometimes, even though I think we all understand the rationale behind them. So I'm really interested in hearing from all of you.
I'll go next, and I'll say that my personal experience is probably somewhere near zero personally. However, as a professional, I think there is a bit of maybe confusion, and sometimes I would even say some distance. By the time the scores are tallied and added up and dispersed and published, we're long past whenever that event was. But overall, I guess I would characterize it as maybe some confusion.
Yeah, I think that's fair, Evie. I have definitely had that experience, especially when I was doing bedside nursing. You'd have like your unit leadership coming out and at staff meetings and stuff, talking a lot about the patient experience and HCAHPS. And if you really didn't have this grasp on what it was really easy to just tune out and not really being able to apply how that impacted you or how you made an impact on those results. For me, it really wasn't until I got a little bit further removed from the floor in my career that it started making sense. And then, being an educator, I'm like, there's a better way that we could be talking to floor staff so that they understand and recognize what their impact is and what their influence is, because they're at the bedside to have the most impact and the most influence because they're right there with the patient. But if bedside nursing really doesn't understand what HCAHPS is, how are they going to have that positive influence?
Yeah, I think I can tap into a little bit about what Terri said. Having began my nursing career in England with socialized medicine and delivery of care, which in my opinion was second to none. We did it without the fear of people having to turn in a survey and grading us on a scale of 1 to 5. Then I moved over to the United States, and it was a very different environment, and the perception of healthcare very different from both the caregivers and the people that receive the care, that being the patients. It's almost I hate to even say the word, but the entitlement that some patients feel that they should have because they are sick. Now, that doesn't sound very positive, but I think that we put so much emphasis on patient satisfaction or the ability to assess patient satisfaction. We've sometimes forgotten the why behind why we all started this. And we want the experience to be as positive as it possibly can, but the experience in hospital is not exactly one of the happiest times for majority of our patients. And so I always struggle with, what are we trying to achieve here? You're just giving someone a terrible diagnosis, they're in a lot of pain, or they're going to lose a loved one. But how was the experience? What do you think the experience was like? It was terrible. So I think we have to sometimes regroup, especially from the med surg nurse who deals with a lot of patients and families and situations that despite everything that they try, there's absolutely no way that they're going to get a 5 out of 5 because the food was cold, the coffee didn't taste good, but yet the nurse takes the brunt for all of that. And this can be one of our biggest challenges sometimes with patient satisfaction. I certainly see the reason for it. We have competition, we have choice with managed care, and we want people to choose our facilities. But I think we have to still remember that the core of care delivery should come from the heart rather than being held to ransom because of what a survey may say.
I think that's a fascinating perspective, Carolyn. And it made me wonder, maybe you could tell me a little bit about where did this start? What was the intention? Because you mentioned, I think most of us understand what the intention behind it was and where it came from. And I'd be interested in trying to understand what med surg nurses can do to influence HCAHPS scores they can influence. And what does that look like? I'm really interested in learning from all three of you what your perspectives are.
So a little bit of very condensed history as far as HCAHPS. Before it was HCAHPS, there was some, I think it was 2002, the Center for Medicaid Services and Medicaid and Medicare Services. They partnered with other federal organizations. And basically the bottom line is a uniform standard to measure the performance and the care of taking care of those patients. So these hospitals are looking to be reimbursed for patients that come in receiving Medicare and Medicaid.
Spot on, Eva. It's absolutely the reason it all came to be. Mm-hmm. And growing up in England, nursing in England, and Terri in Canada, this was never an issue, but yet we still delivered great care. But I understand that to get service agreements and contracts renewed, it has to be tied to the fact that the facility is somewhere a patient wants to go. And I never thought as a med surg nurse, I would talk about finances and care delivery in the same conversation, but that's the system that we have and that's what we have to embrace. But the other thing to add here is when there's an experience in a positive way, then you're more likely to want to go back to that place that gave you a good experience. You're more likely to refer your family and your friends. And that comes into play as well with recognizing the facility as the place to go to receive the best care. I think sometimes as med surg nurses, we forget as well that we cannot fix everything. We have no control if the food is cold or the bed isn't comfortable because we get these services from third parties or different departments. And despite everything that we do, if that's the key driver, then we're never going to get a good satisfaction score, even though we delivered the most wonderful nursing care ever.
That's, Caroline, what you said that I think is important. And one of the things that I would not push back, but I would expand on is that as med surg nurses, I think we as nurses, we have a good idea that we cannot meet the standard in a lot of cases based on the measurements that we're given. You mentioned the food service. That is a huge question and a response from a lot of patients where they base their care of having been in the hospital. They will base their care on how much food or how timely it was delivered You mentioned the hot coffee. And while we may laugh at those while we're working, those are very important to patients. Again, we as nurses may not have that control, but how do we convey that to the patient? Because the patient will see us the most. And I think that's where that disconnect comes.
Yeah, that's a great question. Yeah.
It is a good question, Evie. And really, you bring up a valuable point of making sure that we are managing expectations for our patient. That doesn't tell them like, hey, just the coffee's always cold in the morning. Not that quite of expectation, but making sure that you're setting precedent on you're in the hospital and things run on a different timeline. So when the doctor says that you're going to discharge today, he doesn't mean in 10 minutes because we have to get your medications and your home equipment and whatever else in alignment. It's really taking that time to educate your patient on what is going to happen and what the timeline is realistically. I know that in my organization, when we started looking at our HCAPS and how nursing could impact that, we looked at the nursing specific questions because luckily the place I work, our leaders will filter out and focus on job specific questions. So if the complaint is that the food is cold, they're going to go talk to our nutrition department about that. So nursing specific questions are, my nurse educated me about my medications. So if we're scoring low on that, then that's the push, right? With our nurses is you are required and obligated to educate your patients about the medications that you're giving them. Do it. Go get that done. Or timeliness on answering call lights. So that falls on nursing. And if the patient's perception is that you're not answering their call light in a timely manner, then they're going to mark you down on that. And so making sure you're setting that expectation. When you're orienting a patient to their room, our goal is to answer your call light within 90 seconds. So now they know if it's been less than 90 seconds, then I guess I'm okay. And if it's over 90 seconds, then it's excessive in their mind. You know what I mean? So managing those expectations is really important with your patient. And then on the things that are out of your control but are going wrong, if you acknowledge those and do what you can to try and make those better, cold food, I'll reheat it, bad coffee, let me see if I can do something to help you with that. Those patients are less likely to complain because you went that extra mile to make their stay better.
As nurses, we seem to be perceived or treated as if we are hospitality workers more than nurses. So are surveys like this, are they pushing the pendulum in the wrong direction, or at least pushing it to the extreme, to the point where nurses we're not really taking care of patients and we're not using our knowledge and our skills. We are just there to be hospitality, high paid, if you will, hospitality servers.
That there is a joke, isn't it, that goes around that the H of the sign as you pull into the hospital is for hotel and not hospital. And there is definitely, I think, some truth to that. From the patient's perspective, though, I think that there is an expectation that we are a service industry. We do provide a service, but it's very different than an experience at a vacation resort or walking around Disney World, for example. I actually got access to some Press Ganey scores we use in our facilities. And one thing that we've improved upon with the process, I think, of patient satisfaction is the timeliness in which we get the results. We get them in our division now every week. I don't quite know how that happens, but we get them every week. So it's more realistic. The more the ability to take this back to the team and say, this is what's going well. And just looking at some of these comments, courteous, compassionate, caring, I was very impressed. But then when I was able to eat, the quality of food was excellent. But due to my medication, I had no desire to eat anything. Food is the highlight of a lot of our patients' days, and yet the treatments that we have orders for can come into play with that. And as a result of that, you get a negative survey. People were kind. People were wonderful. I felt safe. All of the core elements that patients want when they come into this strange environment called a hospital. And then we get, the food was cold, food was great, food was hot. It's perception. That's the other thing with these patient satisfaction scores. And I think the communication that we have with our patients when they're first admitted can help them understand what's going to happen, establish a connection with the patient. And that in itself might help increase scores or at least get positive comments along the way.
I think the other thing that we need to remember about these scores and the people who are taking them is not every admission is planned. In fact, a lot of them are not. So you could have wonderfully positive experience scores from patients who had a planned joint surgery. They knew they were coming for months at a time. They went to their joint camp. They did all the things that they were supposed to. And then they were just so happy to be here. Everything happened exactly like they were told. Everything was amazing, sunshine and roses. And then the next patient who came in was a trauma patient on their way to work, got hit by a car. And this was not how they planned their day. And so it doesn't matter how to the letter of their care we are, because they anticipated going to work today instead of the hospital. There really isn't anything that we can do or say that's going to make their experience amazing because they're not at work. So you always have to balance your reaction to these scores with that understanding of who is our audience. These patients have their lives disrupted.
And I think at the end of the day, we have to realize that this goes along with the territory. Healthcare is delivered in the United States and reimbursement occurs on a performance-based criteria.
Exactly.
And as long as the nurse is doing the very best that they can within their scope of practice and within a reasonable request, that's the best that we can hope for. And as a nurse leader, when I was a clinical leader, I tried very much not to put so much emphasis on reviewing scores, but it also, though, can be a great motivator when you have a positive comment. And also when there is an area for opportunity, understanding how things could go better. At the end of the day, though, I've just come to the conclusion that there are certain things that we just cannot control. The system is the way it is. These scores are going to be with us. We just have to recommit to being the best nurse that we can possibly be and do the best that we can given the situations that present to us. It's not our fault if the OR schedule is running late. Yet someone was coming in for scheduled surgery and they're excited to get a new hip or a new knee and not be in pain anymore, but they had to wait 2 hours longer. It's all about the way we message that, of course, and communicate that with the patient. This is the way it's going to be, but this is the reason why it's going to be this way. And we are all very aware of the fact that we want to make this as good of a situation as we can, given what we're faced with.
What strikes me about what you just said on the heels of what Alyssa said earlier is really, it comes down to customer service 101, doesn't it? In a way, I was sitting reflecting on listening to both of you.
It's exactly what it is. Yeah.
And it struck me like I'm upset with customer service that I'm getting or not getting, obviously, in some instance. And one of the fastest and best ways to de-escalate people is to communicate. Reset expectations, be clear and honest, apologize where warranted. It just strikes me that when there's things that are outside of your control, Carolyn, like you were just saying with the OR being backed up or the fact that we don't manage the food services, how we approach things within our control or out of them might really make a difference in our patient satisfaction scores by being honest and open and acknowledging and empathy and all of those great things we learned about in Communication 101 in nursing school.
Right. That's important, Terri. And I like establishing a rapport with your patients, which is what I aim to do. And days when I've had a patient comes in at an admission, I'm upfront with that patient. I'm not ignoring you. But I do have some patients who have some more pressing needs. Please do call, of course, if you need something, but can you just allow that I may be with that patient who has some more urgent needs and things like that. So again, I'm upfront. I'm trying to build that rapport. One of the things I do as well, and I try to do this consistently, not always, but I try to think about doing it consistently, is when I enter a patient's room, I let the patient know who I am, of course, introducing myself, but I also tell the patient, if you need something, please let me know or let the tech know while we're here so we can bring whatever those items are all at one time. That way, you're not waiting for us. You have what you need and you're not having to feel like you're waiting a long time and being ignored. So if it's a snack or water or ice, we can bring all of that right now. So those little things like that seem to make a big difference. And most of my patients were able to do a lot for themselves or a number of things for themselves. So I think establishing that rapport and communicating in the beginning, in the middle, and in the end, communicating throughout the time that you're with that patient does help.
Well, and the other thing you were describing, Evie, is anticipating their needs. And so if we're able to get on top of it, where we're asking them beforehand, what can I do for you before it's a patient request? A lot of times that makes them feel very well taken care of as well. pain meds are coming up soon. How are you feeling? And oh, look, the water looks like that's almost done. And gosh, you haven't peed in a while. Get up. And if you're putting all of that on your timeline when you have time and you can anticipate their needs, you're not going to feel that rush of, oh, you want to get up and pee right now? It's 6:55. And that anticipatory cares that you can do for your patient really will save you in the end. One of the things that we do at our facility is that hourly rounding, which sounded terrible in the beginning, but once you got in the habit of rounding, it actually saves you so much time ultimately, because you're going in the room. What else do I need to do while I'm in there? And ultimately the efficiency has gone up. So
just by being present, just by being visible, you may not do a thing for that patient, but just by going into the room and saying, how are you doing? Do you need anything? Can I help you to the bathroom? Can I fill up your pitcher?
Exactly.
Anticipating those needs is going to do as much for scores as anything else. You made me think about something else as well. Obviously, our primary audience here are Med Surg nurses, but before the patient gets to us, where have they come from? They've either been a direct admission or they've come through the emergency room, and expectations in different areas are very different. In the emergency room, it's their emergency and they want seeing 5 minutes ago and they want taken care of and they want it immediately. Think about outpatient surgery. It's a lot more planned. It's a lot more deliberate. The time frame is laid out a little bit more in a little bit more of a structured fashion. But once they get to the floor, it's free reign. There's all sorts of things that are going to go on. And sometimes it's very hard to coordinate all of that. And so that's important, I think, to explain to our patients as well. Yes, in the ER, you needed this test and this test, but now you're on the floor. You might go down to radiology in the morning. You might get your CAT scan in the afternoon. We'll try our best to cohort things together, but you've got 3-4 different departments all working in tandem with everyone, and it's going to be a different flow. And I think the comments that we see are very much reflective of the environment in which the care has been received. If your patient doesn't get something 5 minutes ago in the ER, then in their eyes, the nurses have failed because it's an emergency. So that's something for a med surg nurse to appreciate. If the patient arrives upset, angry, frustrated, cold, hungry, they've been in the ER all day long. Of course, there's something called triage, and the patient doesn't want to know that someone's more important than them. They are the focus when they arrive in the ER.
That's such a valid point, Caroline. I think one thing that we take for granted once our patients are admitted is we just have them. We have them. They're here. We can do what we want with them when we can. But yeah, when they're in the emergency room or coming in through outpatient, they get them for that 30 minutes or they get them for that appointment, and then the patient leaves. And so they're trying to cram as much as they can in. And the attitude completely changes because, hey, man, I got you. You're admitted now. I can do what I want to you when I can. And so helping our patients understand that time slows down. Hospital standard time, it's what I was talking about before. Time just slows down a little bit, because we feel like we have time, right? We have more time to get things done, and we have a larger amount of patients to get things done with. So again, it all comes down to that setting expectations, making sure that you are letting your patient know what they can anticipate, and that's realistic, building that rapport like Evie was talking about. And then, there are some things that we're just not going to be able to control, and being able to speak to that and roll with the punches with your patient, I think is really important.
One of the things, again, as I listen to y'all talk about what your personal experience with this and these scores are, is I have a twofold question. And my first would be, do most employers act like Caroline's or what Caroline's experienced in terms of recognizing you're going to have some people that just, they had a bad experience, maybe legitimately or not, and there's nothing you're going to do to move that needle. And it could be for reasons that you could control or reasons that you couldn't control, including their own expectations. Is there a recognition that you're not going to get a perfect 5 every time? And is that communicated and shared with the staff so that sort of pressures off you to be a little more authentic and work effectively? Because I could see, and this leads to my second question, I could see a focus on scores impacting the care that we actually do give, as well as what our experiences are more broadly within nursing. And I'll bring up a point that we haven't talked about so far, which is some of the unintended consequences of things like HCAHPS, which I know for a fact include clinical experiences in nursing students who, because of these HCAHPS scores, haven't been allowed to do some of the things clinically that I know I had the chance to do when I was in nursing school, and probably you guys as well? And are we doing a disservice overall to the profession by focusing on a score? So I'm just interested in your perspectives on that.
Great question. Loaded questions with the clock ticking. But I think from my perspective, I think the way that this information is delivered is crucial to motivating your team and having them continue to do the best job that they possibly can. As I said earlier, at the end of the day, this isn't going to go away. We have to have an objective measurement, but objective on whose part. And sometimes the verbatim comments, I really put a lot of weight on them, because sometimes, although we don't identify these patients, nurses can remember certain situations and they will say, it doesn't matter what I did with that patient, nothing was going to be good enough for them. Or I barely had to do a thing and they thought we were wonderful. This dealing with perception is probably the biggest struggle. And so I think from the leadership perspective, it all comes down to delivery and the way that the information is shared with the team to be used as a motivator. I feel like we're running out of time, and I feel like this would be a good part 2 for another conversation. But
I think so.
I don't know whether Alyssa or Evie have anything else to answer your question.
I wanted to answer Terri, your first question. I would say no. I don't think the dissemination is, as you explained it, or even Caroline or Alyssa, I don't think the dissemination is clear. And I think the dissemination comes with added weight and pressure on the staff. I really do believe that. Having said that, that doesn't mean that we can't, as nurses, that we can't find ways to improve. But I do think that weight is there. And again, as I mentioned earlier, one of the unintended consequences is that this pendulum has pushed so far that we do tend to focus on scores, and we do maybe miss some of those moments where we can connect just on a compassionate human level because of the score pressure.
I would just piggyback onto that. I really think it depends on the leader. I've had a lot of different bedside unit managers in my career, and some of them were very focused on the number and the score. And some of them were more focused on the trends. And I think the trends are more important, because if you are trending that you have an issue in a particular area, that I find to be more reliable than this patient had a bad day and wrote you a bad review. If you are seeing a trended problem that nurses are not educating their patients, or that the communication of the care team was poor, or whatever it is, right? The trended issue is more valid in my mind. And the leadership team here at the really high level is really good at looking at those trends. At the individual unit level, those management styles vary. And so it depends. When I listen to you guys talk about bedside nursing in Canada and the UK, where you don't have the monkey on your back, that sounds amazing. And if we could get to a point where bedside nurses really had that empowerment to just be the best nurses that they were and not worry about it, that would be amazing. Because ultimately, at the end of the day, nurses want to do the right thing. They want to provide exceptional patient care. And if that was reflected in their score, whether they knew that there was going to be a score or not, I honestly think nurses would do well without having to worry about those surveys.
Mm-hmm. Alyssa, you make some excellent points, as do you, Terri and Evie. Thank you very much for some really excellent dialogue. And I really think a part 2 is on the cards for this. In wrapping up, it's funny that I suddenly thought about our tagline for AMSN: compassion, commitment, connection. Now, if we tie that into patient satisfaction and doing the best that we can, it comes together beautifully. And so on that note, we will wrap this edition of the AMSN podcast, Med Surg Moments, up, and hope that all of our listeners will come back next time and join us for another topic.
We look forward to connecting with you on the next episode of Med Surg Moments, the AMSN podcast. In the meantime, we want to hear from you. Send us your questions, topic ideas, and feedback to amsnpod@amsn.org. That's amsnpod@amsn.org.
We'd also like to remind you to become a member of AMSN or renew your membership at www.amsn.org. You receive lots of cool benefits and perks, such as discounted pricing on the annual convention and continuing education.
We encourage you to help us spread the word and subscribe to the Med Surg Moments podcast via your smartphone podcast app to receive notifications of future episodes. Please be sure to leave us a review and recommend Med Surg Moments wherever you get your podcasts to help us reach even more listeners.
We invite you to join the conversation by sharing your ideas and questions on AMSN's Facebook, Instagram, LinkedIn, or Twitter pages, and don't forget to add hashtag MedSurgMoments to your posts. Simply enter AMSN in the search field on any of these social media platforms to connect with us.
The content within the Med Surg Moments podcast represents the views, thoughts, and opinions of the co-hosts and may not necessarily reflect the views, thoughts, and opinions of the Academy of Medical Surgical Nurses.
Until next time, I'm Evie.
I'm Chelsea.
And Alyssa. And always remember, Med Surg Moments is a moment in our lives, a moment in our med surg careers that makes a huge difference.